Hello friends, so I'll be talking on this drug Ivabradine under the drug series for all the trainees. So it's just a brief overview over maybe 5 to 8 minutes. So the mechanism of action of Ivabradine is mainly on the SA node F current. So there is this F channels that are present, which are precisely called HCN channels, which is hyperpolarization activated cyclic nucleotide channels. And these channels are where the F current sort of gets generated by the sodium entry and the potassium exit through these channels. So this is where the Ivabradine acts predominantly on the SA node on the HCN channels or the F current channels. So that is where it acts. And what it does is it blocks the entry of the sodium and exit of the potassium by acting on the HCN channels. As you see, this red one is the Ivabradine. It blocks this channel so that the sodium doesn't enter and the potassium doesn't exit these channels. And by doing this, it prevents this F channel currents and it inhibits the SA node. So by doing this, it causes slowing of the diastolic depolarization. As you see, the normal depolarization is the black one. And so by acting on these channels, it slows down this diastolic depolarization. So this is another pictorial representation where your sodium influx and potassium efflux is prevented by this Ivabradine. So sodium doesn't enter, potassium doesn't exit, and this F current sort of gets affected, and there is slowing of diastolic depolarization. So this is in essence the mechanism of action of Ivabradine. So let's look into what has been the evidence for Ivabradine. So there are three important trials, maybe useful for all the trainees to know about its possible role in cardiac conditions. So there is this SHIFT trial, there is a beautiful trial and Signify trial, all nice names for trainees to remember. So the SHIFT trial was from the Swedish group, which came in 2010 in the Lancet. So the hypothesis of this trial was increase in the resting heart rate, so increases the risk factors for the adverse outcomes in cardiac patients. So this was a randomized double-blind controlled trial. So the inclusion criteria in this SHIFT trial was patients with symptomatic heart failure with LV ejection fraction of less than or equal to 35%, and they had to have a heart rate of more than or equal to 70 per minute. And the primary endpoint was the composite of cardiovascular. See, any cardiac sort of studies you look, the outcomes are usually measured with the composite endpoints, which is a composite of cardiovascular death or hospitalization due to worsening of the heart failure symptoms, or any heart failure symptoms needing hospitalization was the primary endpoint they looked at. Median follow-up in this SHIFT trial was 22.9 days, and Ivabradine was given for 7.5 milligram twice a day was given in this particular study. So when you look at the results, so they had 6,558 patients, 3,268 in the Ivabradine group, 3,290 in the Ivabradine group. If you look at the primary endpoint, which is a composite of cardiovascular death and admission due to worsening of heart failure, it was significantly less in Ivabradine group as compared to the placebo group, and that was statistically significant. And the hospitalization due to heart failure also was significantly less in the Ivabradine group, 16% as compared to 21% in the placebo group. And the deaths due to heart failure also, as you see, was significantly less in Ivabradine group as compared to the placebo group. So this raised a lot of enthusiasm with the usage of Ivabradine in heart failure. But then the subsequent studies did not maintain this enthusiasm. So we'll look into it. And the symptomatic bradycardia, as you see, was more in Ivabradine, was 5% as compared to the placebo group, which was 1%, which is expected because Ivabradine predominantly acts by causing bradycardia or the lessening the heart rate. So here, then they did a subgroup analysis. They divided the patients with heart rate of more than or equal to 75 and compared to patients with heart rate less than 75. And they found the effect size of Ivabradine was found to be more significant in patients who had a heart rate of more than 75, which means the beneficial effect was found to be more in patients who had a higher heart rate of more than 75. Even with all-cause mortality, it was less where the heart rate was high. And even the hospitalization due to heart failure was found to be significantly less in patients who had a higher heart rate of more than 75 as compared to the group which had lesser heart rate. So which means to say the effect of this Ivabradine seemed to be more prevailing or present in patients with a heart rate more than 75 per minute. So this was the shift trial, and this raised the enthusiasm that possibly Ivabradine holds good. But then the subsequent analysis and the editorial does talk about the limitations. So the limitations of this study was 90% of those patients were on beta blockers. So to exactly say whether Ivabradine made a difference or whether the fact that these patients were on beta blocker made a difference is something that is argued. And here they found that 23% of the patients who were on beta blockers attained, only 23 patients had the target dose, which means the optimization of the beta blockade had not happened in these patients. So that is where the arguments came in, that possibly optimization on beta blockers should first happen before one embarks on putting on Ivabradine. And they found that 56% of the patients had more than 50% of the target dose, which means to say, although the 90% of the beta of the patients were on beta blockers, the large proportion of them had not attained the target dose on the beta blocker. And for these patients to say Ivabradine had a benefit without optimizing the beta blockade in these patients is something that has been looked at as a significant limitations in this particular shift trial. So this was the gaps that prevailed in this shift study. And then this study had come in 2010. Before this, there was this beautiful trial that had come, again that came in Lancet, done by UK investigators. So in this beautiful trial, the inclusion criteria was symptomatic heart failure with LV ejection fraction less than 40%. And where they took heart rate inclusion criteria, in the shift trial, as you see, the heart rate had to be more than 70. Here it had to be 60 per minute. Here again, the primary endpoint was to look at the composite of cardiovascular death, worsening of heart failure, or hospital admission due to myocardial infarction. And Ivabradine here, they use the dose of 5 to 7.5 milligram, because in shift trial, they use 7.5 mg BD. Here, they started with 5 and then they increased to 7.5 mg BD. This was a little larger study, 10,917 patients, 5,479 in Ivabradine and 5,438 in the placebo group. So as you see, the primary endpoint, there was no difference. The composite of cardiovascular death or worsening of heart failure or hospital admission due to MI, there's no difference between the Ivabradine group and the placebo group. So this is a beautiful trial that came. So the shift trial, although was enthusiastic, the beautiful trial was negative. Then came this particular trial, which is the most latest, Signify trial. So this came in NEJM in 2014. Here, the type of patients they looked was what non-heart failure. So they looked at Ivabradine in stable coronary artery disease without clinical heart failure, done as a multicentric study. Predominantly UK group and Italian group were present. So here the inclusion criteria were where they had a stable coronary artery disease with the heart rate of 70 per minute. And the target heart rate they tried to achieve was 55 to 60 per minute. So that was the target heart rate they had to attain by using Ivabradine. Okay. So, and the primary endpoint was composite of cardiovascular death and acute MI. And again here, the Ivabradine, they used a much higher dose, 10 mg twice a day they used. And again, this was a very large study. As you see, it was much larger study than the shift study and the beautiful study with 19,102 patients. 9,550 in the Ivabradine and 9,552 in the placebo. Primary endpoint, which is a composite of cardiovascular death and acute MI, there was no difference between Ivabradine group and placebo. So this possibly tempered the enthusiasm. Although the shift trial and the beautiful trial was more of heart failure, this was a stable coronary artery disease without overt clinical heart failure they looked at, and they found there was no difference in the endpoint. So again, going on to show that possibly Ivabradine didn't hold promise in this stable coronary artery disease. So very quickly, we'll look into the adverse events of Ivabradine. So Ivabradine, as we know, predominantly acts by reducing the heart rate. So symptomatic bradycardia, as you saw in shift trial, was around 5%. And it cannot be used in patients with atrial fibrillation because it can induce atrial fibrillation. And it can induce torsades de pointes, and multiple heart blocks is something that can occur with Ivabradine. So one thing for all the trainees to bear in mind is in atrial fibrillation, Ivabradine cannot be used because it can worsen and it can induce atrial fibrillation. And the shift trial, as you saw the data, so symptomatic bradycardia occurred in 5% of the patients in shift trial. And hypertension is another side effect of Ivabradine. And there is this unique side effects in Ivabradine called phosphines. Phosphines is in retina, there are these F channels, and Ivabradine can act there, and it can cause the lightning symptoms, like it's something like floaters. So they can have these phosphines, and this was present in 3% of the patients in SHIFT trial. So the eye symptoms also can manifest in a small percentage of patients, and this was shown in the SHIFT trial. So they have basically some sort of a lightning sort of a feeling in the eye or in the visual fields. It's a bit like a floaters is what has been documented. And so the metabolism of Ivabradine happens with CYP, cytochrome P, 3A4, and there are certain drugs which get metabolized through this pathway. And mainly, if any patient is on diltiazem or verapamil, so Ivabradine should not be used because they also act through CYP3A4 metabolism, and it can significantly increase the levels of Ivabradine. So for all the listeners, you can bear in mind certain drugs which act through metabolism of cytochrome 3A4. Those drugs should be used with caution with Ivabradine because they can significantly increase the serum concentration of Ivabradine, especially in cardiac patients. Anyone who's on verapamil and diltiazem, so Ivabradine should not be used. So contraindications of Ivabradine. So someone with severe hypotension, blood pressure less than 90/60, Ivabradine cannot be used. Or anyone with a decompensated heart failure, or anyone who is having AV blocks or significant symptomatic blocks or heart rate less than 60, Ivabradine should not be used. So this is a brief overview. So we spoke about mechanism of actions, and three important trials for you to remember is the SHIFT trial, Beautiful trial, and Signify trial. Signify is the most latest, 2014 in coronary artery, large group of patients. Ivabradine did not show promise in the primary composite endpoint, which was the cardiac related death and MI incidence. But the SHIFT trial was sort of compelling for us to believe that it will help in heart failure patients with regards to the endpoints. And then we spoke about the few adverse events and the contraindications. So that's a brief overview. So thank you one and all. And I think contraindication, liver impairment also is one of the contraindications. So thank you one and all. So end with this beautiful quote by Plato, only the dead have seen the end of war. So thank you.